Welcome to the Explainer. Okay, picture this. You're a junior doctor, it's 2 a.m. on the respiratory ward, and suddenly your pager goes off. You've got a patient in acute respiratory distress, and they are struggling for every single breath. The decisions you make in the next few minutes are absolutely critical. Today, we're going to arm you with the clinical framework you need to navigate this exact scenario. We're mastering mechanical ventilation, and specifically, we're focusing on how you choose between invasive and non-invasive strategies.
We've got a really structured clinical decision tree today that's going to guide you all the way from the underlying physiology straight to bedside action. We'll breeze through the basics of ventilation, uncover the physiological effects of positive pressure, and figure out exactly when to use a non-invasive approach. Then, we'll talk about when it's absolutely contraindicated, the very real risks of invasive intubation, and finally, how to make the right call for your patient when it really counts.
Let's start right at the foundation. Your patient is in acute respiratory failure. Their spontaneous breathing just isn't cutting it anymore. Blood oxygenation is tanking, or carbon dioxide is rapidly accumulating. You have to make a choice, and choosing the right tool, right now, is literally the difference between saving a life and causing harm. So what exactly are your primary tools?
It basically comes down to two paradigms. On one hand, you have invasive mechanical ventilation. This means placing an endotracheal or nasotracheal tube directly into the airway. It gives you definitive total control, but it requires heavy sedation and carries a really high risk of complications. On the other hand, you have non-invasive ventilation, or NIV. This relies on delivering positive pressure through an external interface, like a nasal or full-face mask. It's fantastic because it preserves the patient's natural airway and glottic function, but, and this is a huge but, it absolutely requires a conscious, cooperative patient to actually work.
So let's dig into the physics of how this actually supports the lungs.
Whether you end up using a tube or a mask, you're applying positive pressure. Think about the sheer physical work a patient in respiratory distress is doing just to pull air in. In a diseased lung, the effort is massive. The patient is completely exhausted. By applying positive pressure, the ventilator steps in and actively unloads those exhausted respiratory muscles. It essentially shares the work of breathing, which prevents total muscular failure.
But you know, the physiology goes way deeper than just easing the work of breathing. Beyond the lungs themselves, positive pressure profoundly alters cardiopulmonary dynamics. It boosts alveolar ventilation to clear out that dangerous CO2, and it pops open collapsed alveoli to improve oxygenation. Crucially, it increases intrathoracic pressure, which decreases venous return to the heart. Now, this is a super important point to remember on the wards. If your patient has fluid overload or heart failure, decreasing that venous return can actually help their cardiac function. But if they're hypovolemic, it can cause their blood pressure to completely crash.
Now that we understand the how, let's talk about the when. When do we reach for the mask as our first-line therapy?
What's really fascinating here is that there are very specific arterial blood gas thresholds that act as your evidence-based trigger. Let's say your patient is having a COPD exacerbation. If their ABG shows a pH less than 7.35 and a pCO2 greater than 45 millimeters of mercury, you are looking at acute hypercapnic respiratory failure with respiratory acidosis. That right there is the exact moment you need to initiate NIV to normalize that carbon dioxide.
When we look at the clinical guidelines, NIV has the absolute strongest evidence base for acute COPD exacerbations. It significantly reduces both the need for intubation and ICU mortality. It's also highly effective for cardiogenic pulmonary edema, primarily because that positive pressure unloads the respiratory muscles and decreases venous return, which takes a massive strain off a failing left ventricle. We also see great benefits in immunocompromised patients, where avoiding the infectious risks of a tube is paramount.
But of course, NIV is not some kind of magic wand.
Recognizing its limitations is a must-have skill for junior doctors. You have to know when a mask is simply not going to cut it. If you encounter any absolute contraindications, NIV isn't just inappropriate, it's highly dangerous. If your patient has severe encephalopathy, is actively vomiting, or just can't protect their own airway, strapping a pressurized mask to their face drastically increases the risk of a fatal aspiration. Likewise, if they're hemodynamically unstable or already in respiratory arrest, you don't have time to trial a mask. They need immediate, definitive, invasive airway management.
And that brings us to a really crucial warning. NIV requires incredibly careful patient selection, and it comes with a real risk of treatment failure, especially in patients with severe hypoxemia. If you start NIV, you have to monitor that patient like a hawk. If their breathing doesn't improve, or if they keep tiring out, do not delay intubation. The data is crystal clear on this. Lingering on a failing non-invasive therapy is devastating for the patient and significantly increases mortality.
Which leads us to the other side of the coin, the cost of definitive control. When NIV is contraindicated or when it fails, we have to intubate. Yes, invasive ventilation gives us total control of the airway and gas exchange, but it brings serious, life-threatening complications that you have to constantly manage. The big one is ventilator-induced lung injury, or VILI. This is the tragic irony where the very machine keeping the patient alive damages their vulnerable lung tissue. If we deliver excessive pressure, we cause barotrauma, literally rupturing alveoli and pushing air into the pleural space, which causes a pneumothorax. If we deliver excessive volume, we cause volutrauma, overstretching the lung tissue and sparking a severe inflammatory response.
It really is a cascade of complications, and it highlights exactly why an endotracheal tube is a necessary but dangerous last resort. First, by inserting the tube, we completely bypass the body's natural pharyngeal defenses. Next, we're forced to heavily sedate the patient, which can lead to diaphragm atrophy and cardiovascular depression. And because the airway is now completely open to the ventilator circuit, the risk of ventilator-associated pneumonia, or VAP, skyrockets to a staggering 26% incidence rate.
So, how do we bring all of this together when it actually counts?
Let's synthesize this physiological data and guideline reporting directly back to your bedside decision-making. Your primary goal is to identify the underlying cause of the respiratory failure immediately. If it's a COPD exacerbation or pulmonary edema, and the patient is conscious and cooperative, intervene early with NIV to save them from the risks of the tube. But remember, you must constantly reassess. Watch their work of breathing closely, check those ABGs, and if they are failing, escalate to invasive intubation without hesitation. I'm going to leave you with a provocative thought to chew on before your very next shift. When you apply a therapy to a rapidly deteriorating patient, ask yourself, is this intervention actually fixing the underlying physiology, or am I just delaying an inevitable intubation because I'm hesitating? Always ensure your treatment is actively reversing the failure, and be ready to adapt instantly to save your patient's life. Thanks for joining this explainer, and good luck out there on the wards.